Good morning. Thanks for the invitation. And I see the nurse introduction. And today we are talk about compassionate opioid tapering. I do not have any financial relationship to disclose. I do get a small amount of royalty from the book Anesthesiology in Training Exam Review. And I am in a speaker bureau of Vortex Pharmaceuticals. So opioid has been used since 1860s when United States used the opioid to treat the wounded soldiers. And within 150 years, United States became the number one country for opioid consumption. As you see from this graph, here standard daily dose per 100,000 people, and you see that USA is in the top. As a result of the increased opioid use, opioid-related death tripled within 15 years. Here you see this graph, number of the death in the y-axis, and 2000 to 2015, any opioid here, and death increased by 294%. Methadone and semi-synthetic drugs also increased by 304%, and heroin became available in the street in 2010, and within 5 years, heroin-related death increased by 600%. Fentanyl came late in the game in 2013, and if you look at your spam folder, you see that a lot of online pharmacies sending you spam mail that buy fentanyl, buy Viagra, and this is became very available at this time, and within only 2 years, fentanyl-related death increased by 1,000%. Another interesting fact, we see that when daily MME is related to the number of the death, that means lower MME has lower death, and higher MME has higher risk of death. So in this context, in 2016, Center for Disease Control published this guideline, as you know, and this guideline basically saying that don't prescribe opioid for non-cancer pain, and use normal pharmacological therapy at first. And when you use opioid, use immediate release only for a short period of time, and assess the patient's improvement in pain and quality of life. And if it doesn't improve the quality of life, then talk about opioid weaning. And the other thing they say, this is the kind of main thing we are going to discuss from this guideline, but there are other things they said. Avoid increasing the dose of more than 90 MME, and not prescribe opioid and benzodiazepine together. Always take the patient compliance, urine drug testing, and PDMP. And clinicians should offer or arrange buprenorphine or methadone when there is a sign of opioid use disorder. But guideline is say that when patient is not improving, then consider opioid weaning. But it's not easy to have this conversation with the patient. And it's very challenging. You say you have too many people are dying and the situation is out of control. I kind of thought that they're helping you, but right now I have to stop your opioids. It's a difficult conversation because patient want opioid, patient has been on opioid, want medication from you, and you are saying no. So my goal of this talk is how to say no compassionately, how to taper or wean the opioid in a compassionate manner. And this quote I like about Dalai Lama: if you want others to be happy, practice compassion. If you want to be happy, practice compassion. Why we need to care about the compassion? And I can tell you that research has proven over and over that when caregivers show empathy and kindness, the patient will more likely listen and they heal faster. When medicine holds the power to cure, and any care delivery with kindness and compassion can speed the healing process and lead to the better outcome of the patient. These benefits have consistently demonstrated in many branches of the medicine, and opioid weaning process is absolutely no exception. So, when to consider opioid, and you already know in this audience when you should talk about opioid weaning, but I don't like to re-emphasize this couple of points. Then opioid are a very good drug for acute pain conditions, and when this underlying condition like surgery or any particular condition that lead to the opioid use, such as some patient has a fracture or rotator cuff tear, has major surgery, or have a cancer. And when these issues are resolved, then that's the time to talk about that you cannot continue this opioid. And when patient experiences no reduction in pain despite using the opioid, no improvement in function, that's the time to talk about opioid weaning. And sometimes patient asks to reduce the opioid therapy, which is very uncommon, and patient complain of the side effect of the opioid, and this is also not common because then they may not continue the opioid, chronic opioid in the first place. And sometimes they complain of there is opioid use disorder like suicidality and any previous or recent overdose event, and does not adhere to the treatment plan, which you usually check with the UDS and PDMP, and exhibit an unsafe behavior like early refill. They talk about the lost or stolen prescription, buying or borrowing the opioid, and if there is any of the evidence you see, these patients are not eligible for compassionate opioid tapering. They need to go to addiction therapy, medicine referral, and they either inpatient or outpatient rapid opioid tapering should be planned. What are the key elements of compassionate opioid taper? First thing is creating a therapeutic alliance with the patient. You need an excellent patient-provider relationship. Otherwise, this method is not going to work. You do not need to listen rest of the talk, because this is not if you don't have this relationship with the patient, this method is simply not going to work. And this therapeutic bond between the provider and patient should be based on the shared goals: mutual understanding, caring, trust, respect, acknowledgement of the patient, that patient is a person, he's someone's family member, he can be your best friend, he can be your family member. And if you have this kind of bond with the patient, then you start educating them then why we need to taper opioid. So this is the first point. And the second, then make a well-structured, very personalized plan. That what is our goal? What is our, and in the process, patient may develop withdrawal symptoms. How we can prevent the withdrawal symptoms? How to manage pain? And actually, withdrawal symptoms is uncommon in a slow taper plan. We'll go to that point later. And psychological aspects of the dependency. And we set clear goal. The goals should be complete cessation of the lower and more manageable dose. Like someone takes only 7 or 8 tablets of oxycodone a month. I don't mind that. It's fine. When you have a really bad day, you can take opioid, but it's a very good drug. And this should not, I will be less concerned. And then start with a very slow taper. We always say that slow and steady wins the race. The slow taper, reducing the opioid dose by 5% or 10% every month or every 2 months. And alternate opioid pain management. Opioids are not the only pain medicine. Tylenol also a pain medication, and Celebrex also pain medications. We can also try those, and muscle relaxer and pregabalin. medical cannabis. All these options patient should try. If patient doesn't want to take the step, patient worried about that, he's so used to with the opioid and worried about a life without opioid, we can also consider sending them to behavioral health pain psychology therapy. And if you don't have one available, there is online a list of providers who can provide pain cognitive behavioral therapy. I will show you later. And acknowledge the patient's courage. And when patients are able to win even a small dose, then acknowledge that and effort, their courage and effort, and give appreciation, give them congratulations. And so the rest of the slides, I'm going to discuss these points more elaborately, but these are the component of the opioid taper plan, compassionate opioid taper plan. The education is, there is no, I cannot emphasize enough the importance of the education. A lot of times we don't give enough time to the patient to discuss the opioid related side effect. And this is some people may not listen, but there are a lot of people, if you spend time and if you give them, if you answer their questions well, and they will likely listen. Tell them, the patient, that opioid, a lot of things we don't know in the last before 20 years. Now study came out that showed that opioid itself can cause opioid-induced hyperalgesia. Opioid can lower your immunity. Opioid can cause constipation, overdose. Overdose death due to opioid is rising. And endocrinopathy, it can lose your libido. It can cause your erection problem and decreased libido. Some of the things people may not heard before. And because of the immunosuppression, you are more prone to develop disease, even flu. You can have a altered sleep cycle from the opioid use. This component is very important, and also tell them that opioid induced hyperalgesia happen very quickly within our discontinuation of the long-term opioid therapy, like such as remifentanil hyperalgesia. And motivational interviewing, this is actually a big topic. I don't think we have enough time to cover it, but I will just give you some sample statement what the motivational interviewing is, because patient might always say that, oh, I can do that, and make a statement with empathy. It sounds like you have a real concern about reducing your opioid medications. That's completely understandable. Let's explore those together so we can figure out the best way forward. And roll with the resistance. If there is any resistance, they don't want to agree with you, then tell them that it sounds like an idea of tapering of opioid feels overwhelming to you right now. That's completely valid concern. What do you think about? Ask the patient opinion. What do you think about will help make the process more manageable? And at the end, summarize. Then what I am hearing, that you want to feel more control. You understand that opioid is bad, but you just cannot take the step, that you are concerned about how your body will react with the opioid taper. Let's talk about it. Let's think about how we can create a plan that address these concerns. And personalized plan, as I say, everyone, we cannot really go by 5 to 10%. If someone is taking long-acting and short-acting combination, we should touch the long-acting at first. Because they may not feel, this is a slow-releasing drug, they may not feel a big difference. And long-acting at first, then we can give them as needed medicine and gradually tapering of the long-acting one. If someone is taking only 5 oxycodone, try very low dose, try 4.5 a month. And then give reasons that are specific and relevant to the patient. For example, suggest that patient should consider tapering because they have a particular comorbid condition that increases the risk. And set clear goals. The goals should be successful completion of the taper, a resulting opioid cessation, or reaching to a reduced or stable dose. And adjust the taper speed if there's increased plan, Sorry, there's increased pain, and one goal should be to reduce the patient's anxiety by counseling and emotional support or referring to the psychologist. Goals might be to successfully integrate one or more pharmacological and non-opioid therapies. Slow and steady. I cannot emphasize enough this particular topic. Slow and steady wins the race. When you say that, well, you're taking 5 oxycodone, why don't you try 4.5? And a lot of people, I can tell you, will be happy with the plan. But common cause of the failed taper, it has been shown in the studies that too quick. You offer okay, I'm going to give you like only 1 week. 1 week of taper plan, you need to 5 tablets. Only 1 week will be 4, 1 week will be, then it can be, patient will go to some other clinic, patient will not be very happy and need frequent follow-up. I will check with you, so how we are doing. Be patient and non-judgmental. Allow the flexibility and letting the patient know that taper can be paused anytime. If you cannot do it, then they will be more agreeable to take the risk. And pauses are better to just hold up when where they are at the time. That means someone say, I can go below the 4 tablets. That's fine. We can take 4 tablets, but don't increase it. The non-opioid pharmacotherapy there's not a lot of things available, but most people may not like the over-the-counter medicine, and you can give muscle relaxer. But I found out in my own practice, I cannot give you any good reference, and that pregabalin sometimes was very helpful. If you give pregabalin and has a rapid absorption of the pregabalin, make them help them getting euphoria, which normally they get from the opioid. And medical cannabis, I know that it's not available in Florida, so not going to discuss about it. So behavioral health support is vital, very important for successful opioid taper. Some patients are thinking that they're so used to the opioid that they cannot take the risk of tapering. So for them, it is better to send to the behavioral health specialist who can talk about, illuminate their mind that it is, I know that it is hard, but you can do it. There are 2 studies, and this comparative effectiveness of the pain cognitive behavioral therapy. I don't know the result, but their preliminary data showed that helped patient to self-weaning after online cognitive behavioral therapy. So bottom line is, patient provider relationship, number one. You must have a very good patient provider relationship before you can consider compassionate opioid tapering. And patient education, we take a lot of time, use motivational interviewing, and when you agree with the patient statement and listen them and do the counter argument. And the well-structured personalized plan aims to minimize the withdrawal symptoms, manage pain, and address any psychological aspect of the dependency. And also set clear goals. Goals could be complete cessation of the opioid or just a lower and more manageable dose. That will give you only 7 tablets a month. And start with a very slow taper. And as I said, there's absolutely no reason for tapering faster. If someone agree with the opioid weaning, that's a big victory. An alternate opioid pain management, there's not many alternative. We can try pregabalin and behavioral health support. If someone is very resistant, at least convince them to see a behavioral health specialist, or online cognitive behavioral therapy, which I mentioned in the previous slide. And acknowledge that the patient courage and effort, even with a small gain, even they can win from 5 oxycodone to 4.5 oxycodone in a month. That's a big achievement, and congratulate them. That's all I would like to tell in this talk. If you have any questions, I can take few questions.